So good afternoon, and sorry I'm not here live to talk to you, but hopefully this recording will go smoothly. I'm here to talk to you about effective preventive medicine, the new Wessex Formulary, and this is to share with you some work we have been doing in Southampton, Wessex, across our locality, reflecting upon our current outcomes for asthma and thinking about ways of trying to move forward with better prevention treatment. So that's me, Professor Connett. I've got no conflicts of interest with pharma at all in relation to asthma care to declare. I thought I'd start with this slide. It's quite sobering data. What we've got here is the tip of the iceberg for asthma outcomes. We've got asthma mortality rates. The green at the bottom there is the UK for, I think it's 10 to 14-year-olds and then an older age group. And that's the mortality figures compared to other European countries. And you can see that we are by far doing the worst with higher mortality for asthma in childhood compared to the rest of Europe. We have similar outcomes to America and to Canada, but compared to other European countries, we're not doing very well. And I think it's important to reflect on this and to think about why are we doing so badly and what we can do to improve outcomes. And there are two themes that I wanted to bring up, which I think are important, that might be relevant. One is the UK's over-reliance, overuse of beta-2 agonists, of which the most common is salbutamol. And the second I would suggest to you is perhaps the underuse of effective interventions to prevent asthma attacks, and perhaps an underappreciation of the evidence base around treatment choices when we're trying to impact upon outcomes such as acute asthma attacks, of which there is a risk of near fatal or fatal outcomes. So I thought I'd start by just sharing some data to highlight how we might differ from other European countries. This is the Sabina study, and what you can see here is a number of European countries, of which the UK is on the right, and the data is broken down here by mild and moderate to severe asthma. And on the y-axis, we've got the percentage of individuals with asthma using different amounts of SABA. The blue there is 0 to 2 inhalers a year. The orange is 3 to 6. The grey is 7 to 12, and the yellow is 13 or more. And you can see that compared to the rest of the other European countries, in the UK, and this is data for 12 years and above into adulthood, we are using far more salbutamol for moderate to severe asthma than other European countries. Quite interesting how that difference stands out quite strikingly. And if you break down the UK data, we've got here, again on the y-axis, the number of exacerbations, the number of asthma attacks. And the data here now is broken down to using less than 3 salbutamol inhalers a year in blue, or more than 3. And it's broken down for the BTS steps 1 to 5 of asthma severity treatment. And you can see that across the entire spectrum of the patient population, there is an association between the risk of asthma attacks, the frequency with which they occur, and the reliance on SABAs. In all levels, the population that's using more than 3 inhalers a year are at increased risk of asthma attacks compared to lower usage, whatever the severity of the asthma is, according to BTS step. So what's going on here? There's two possible explanations I would suggest. I'm not going to go into detail in these, but it may simply be that the high use of salbutamol is an indicator of poor asthma control. It's a marker of something else that's going on. Something that we're not doing perhaps, or it could be that using large amounts of salbutamol of itself, an overuse of beta-2 agonists, might actually be causing more acute asthma. I think irrespective of which, or it might be both possible reasons, there is clearly something here about salbutamol use in our country that's perhaps excessive. And we need to think about ways of giving less. I've already given a talk, which many of you will have seen, and we published last year our research looking at using as required salbutamol, in particular during the recovery phases of an acute asthma attack, an acute episode of wheeze, rather than a fixed dose weaning regime, using just a third of the doses that would have been required had the fixed dose regimes been followed. But today I want to focus more on how we might consider using more effective preventer treatment to impact upon asthma attacks. Now, these are our BTS sign guidelines. They are, I would suggest, out of date. They are in need of revision. Our 12 and above patients are lumped in with adults. Our pediatric regimes are like this. And what we have is a stepwise approach whereby we're encouraged to give regular inhaled corticosteroids for chronic asthma, and to then think about adding in other agents in those who have poorly controlled symptoms. And that would then include the addition of leukotriene receptor antagonists, long-acting beta agonists, and then an escalation of the dose of inhaled corticosteroids. Now, regular inhaled corticosteroids are highly effective in impacting upon all asthma outcomes, including acute asthma attacks. But I want to be more critical in our examination of those other aspects which are then encouraged when patients continue to have problems. So let's just look at the addition of a long-acting beta-2 agonist to inhaled corticosteroids for chronic asthma in children. Now, this is the Cochrane meta-analysis of the randomized controlled trial evidence that we have for this approach to treatment. And I would suggest that that probably is the best repository of evidence-based practice that we should be looking at, rather than other more convoluted ways of looking at the data. So we have 39 randomized controlled trials in pediatric practice, and the conclusions from the meta-analysis of those 39 studies, of which many had asthma attacks, hospital attendance as an outcome, was that in children with persistent asthma, the combination of LABAs and inhaled steroids does not reduce the risk of exacerbations, an unequivocal statement. And in fact, they also went on to say that perhaps the trend towards increasing risk of admissions with LABAs, irrespective of inhaled steroid dosage, was concerning. So if anything, a slight safety signal suggesting this was not a good approach. So many people are a little bit surprised to read that. That's a direct quote from Cochrane. And it's important to stress that children are not mini adults. There are differences in the asthma phenotype, and there may well be important differences in how they respond to treatment. And this is the statement taken from the adult Cochrane meta-analysis, which says something different to what we see for children. And that's that in adults, there is evidence that adding in a LABA can reduce exacerbations, for example, as measured by the need for oral steroids as rescue therapy. But then again, if you go onto Google and you ask this question, you will again find some conflicting advice and recommendations. And this is the Einstein study. It was done by our colleagues up in Liverpool, working with Glaxo, looking at their patient data. And their conclusions from their research was that actually what we should be doing as recommendations for children not controlled on inhaled steroids is to go to a medium dose of steroids and add in a LABA. And that's the best approach to reduce exacerbation risk. So why are they saying this, and why is this contrary to what the Cochrane review suggests? Well, the devil's always in the detail, and it's important to stress that what's become very fashionable in recent years has been the concept of doing what's called a network meta-analysis. And network meta-analyses are not the same as a proper meta-analysis where you make direct comparisons of different trial interventions. What you have here is the use of what's called indirect evidence. You're looking at common comparators, for example, between low-dose inhaled steroids and low-dose steroids and LABAs, where studies have also compared those treatment regimes with other things such as high steroids and LABAs, and high steroids and LABAs with inhaled steroids, which are low with LABAs. So you've got these common comparators. And I think there's a lot of heterogeneity here in these clinical trials, and it makes it difficult to do this kind of work. They did have individual participant data in this study, to be fair, but even so, I think the strength of the evidence here for these recommendations is far less than what you would have from direct comparative data. And indeed, these researchers did in fact look at the systematic direct meta-analysis of the different outcomes. And what you can see here is that inhaled corticosteroids, either in low, medium, or high dose, had absolutely no difference in outcomes for asthma attacks compared to any other dose of steroids with or without LABA or LTRA. The only thing that these drugs were more effective were placebo, as you can see at the bottom there, where the odds ratio is above 1. And this then leads us on to another consideration, which is what about doses of steroids? We know that inhaled corticosteroids are highly effective, but what about a higher dose versus a lower dose? This has been looked at in 15 randomized controlled trials for beclomethasone, and those studies show no effect on acute asthma. Increasing the dose of beclomethasone does not improve outcomes. There are 51 randomized controlled trials. These are in adults and children, and again, no effects on acute asthma. For budesonide, there are 24 randomized controlled trials. There's just one study that they could identify that showed that 800 versus 200 micrograms a day of budesonide had an impact on acute asthma attacks. One positive study, 79 randomized controlled trials, which are negative for this important outcome measure, which is linked to asthma attacks and poor asthma outcomes, including mortality. So what alternatives do we have? Well, the evidence base that I want to suggest to you that we need to look at a little more closely is that of using MART therapy. From what we know so far, there is good evidence, I would suggest, that adding in LABAs or increasing inhaled steroids is not the answer to reducing asthma attacks on children who are poorly controlled on inhaled steroid doses. But the MART regime, I would suggest to you, does have a good evidence base for benefit. This is nothing new. The COMPASS study, which was 1,000 patients in each of these 3 treatment arms, was published in 2007. Here is a comparison between the use of Seretide in a fixed dose combination with salbutamol as used as required, the use of budesonide eformoterol, Symbicort as a fixed dose combination shown there in orange, with the use of Bricanol as required, and the same Symbicort inhaler being used as a MART regime. And you can see here that the MART regime in light blue outperforms the other treatment approaches with a significant reduction in asthma attacks. And that result has been shown consistently now in 16 randomized controlled trials in children down to the age of 12 and adults, comparing MART with all other treatment options, and it wins every time. The evidence in the 6 to 11-year-olds is not as good. There's one study, it even predates that study, it's 2006. It's got over 100 patients in each treatment arm, and here we had a MART regime of just the 106 turbohaler Symbicort used once daily compared to a fixed dose combination of that device compared to a high dose of inhaled budesonide. And it's interesting to note the detail there that actually the fixed dose budesonide was more effective than the fixed dose combination in Symbicort treatment, which is consistent with that conclusion I showed you from the Cochrane review for the signal that maybe just adding in LABA as a fixed dose treatment with short-acting beta agonists may actually be doing something that's not beneficial. So that's the 6 to 11 data. This is a breakdown of the asthma exacerbations measured either by peak flow fall, extra treatment needs like steroids, and hospitalization. And you can see that the March regime there is performing better than the other treatment options in this age group. So that data has informed our local guidelines for Hampshire and Isle of Wight, and it's shortly to be extended out to our region of shared care across our locality. And essentially for 12 plus, we're trying to avoid the use of salbutamol. We have good evidence and we have license indications for the use of a March regime. We're recommending the Symbicort Turbohaler as a preferred option, environmental considerations being particularly important in preference to the use of MDIs. We're showing the carbon footprint of all the devices that we're recommending to help inform patient and primary care choices of treatment. We do have recourse to the Symbicort MDI for those who cannot use a dry powder device. Relatively small numbers, I would suggest, in this age group. And we have a step-up approach of using the 206 Turbohaler, and we also have the Duo Resp Spiromix dry powder device as an alternative option. We've got the Symbicort reliever therapy option for less severe symptoms, whereby the 206 Turbohaler can be used within license on an as-required basis for those patients with less frequent symptoms that do not justify the use of regular prevention therapy. So that's our 12 plus guideline, very simple for primary care, with a clear message for dry powder, combination inhaled therapies, and an avoidance of salbutamol if at all possible. For our 6 to 11-year-old age group, it's a little more complicated. Again, we are trying to encourage the use of dry powder prevention therapy. Our first line intervention will be regular inhaled corticosteroids. We've got the Pulmicort Turbohaler or the Flixotide Accuhaler as the dry powder options for this age group. We recognise that some children won't be able to use the dry powder in this age group, and so we've also got the option of fluticasone or beclomethasone as an MDI for fixed dose prevention treatment. We thought very hard about it, and in this age group for PRN use, we are remaining with the Salamol, salbutamol, MDI for relief therapy. And that's because we don't have any good guidance anywhere for what to do for emergency treatment of acute wheeze with dry powder salbutamol. So we've kept the MDI here for this age group. But in those patients who are not well controlled in that regime, we then are recommending the Symbicort Turbohaler as a MART regime. The MDI is not licensed in this age group and it's not recommended in this guideline. The Symbicort Turbohaler is licensed for fixed dose treatment. The MART regime is not licensed, but we surveyed our primary care practices and they were happy to have this in the guideline, and it is consistent with NICE recommendations which state that this can be used in patients who fail despite other prevention measures to get control of asthma. So that's what our guideline looks like. If it's not controlling symptoms, we recommend referral to secondary care. On the back of the page, we've got some further information, our diagnostic algorithm. I won't go into that in detail. You've already heard about asthma diagnosis earlier on today, I gather, and this is consistent with that advice, I think, having thought about that. The asthma review advice, I think, is fairly straightforward for primary care. What does an annual review look like, and what other things to think about and address? And also we talk about the consideration of the differential diagnosis. Certainly, I would say that if it's up to me, hyperventilation would be in what asthma is. It's an important component of the disease, I would suggest, in nearly all patients to a variable extent. And we know that interventions to address breathing pattern disorders and occasionally the laryngeal obstruction that can cause inducible obstruction is something to think about and to consider. And also we stress the importance of recognizing that anxiety plays a big part in the phenotype of asthma, not just in the perception of symptoms, but can result in more severe bronchoconstriction and more severe asthma attacks, and so interventions to try to address that through better supportive care is a big part of what we're emphasizing. So that is essentially what we're doing. We're driving a green agenda and making people aware of the carbon footprint of their treatment choices. This is currently available for our primary care practices across Hampshire and Isle of Wight through the ICB. It will shortly be available across our locality through our peer website and also on Healthier Together. It's looking like this. You will have a diagnostic page and a treatment page for the 2 age groups. If you click on one of the age groups, you will get discharge plans, which we developed for our PRN use of salbutamol, and action plans for the 6 to 11-year-olds. We've got 2, one for the use of regular inhaled steroids and one for the MART regime. This is an example of our regular inhaled steroids action plans. Some advice about what asthma control does look like when it's good and when it's not, some hyperlinks to inhaler techniques, and some action plan advice for managing acute symptoms. For our older age group, for the 12 plus, we've got 3 action plans, one for using Symbicort reliever therapy as necessary, one for a MART regime using dry powder, and one for a MART regime using the MDI device. Subtle differences in the doses that are recommended around those different treatment options, and so 3 different action plans. And here's an example of the MART plan, advising the safe use of the MART regime within license with safety netting for referral to hospital for acute severe symptoms. So that's my talk. I hope you found that interesting and instructive. I'm sorry I'm not here with you to take questions live, but this is my email address, and I would very happily feedback to you should you want to ask any further questions. So thank you very much. I hope you enjoyed that talk, and I'll leave it at that.